So I have no disclosures. So when I was thinking about what to talk about with this topic, which is quite broad, I of course went to Google, which is where we always go for any inspiration or information we need, and I looked up the word tough. So in terms of the toughest fetal diagnoses, you know, tough means involving considerable difficulty or hardship, requiring great determination or effort. And I thought, yes, this is fetal echo. And when I looked at the synonyms, we have arduous, strenuous, grueling, difficult, hard, stressful, backbreaking. I again thought, yes, this is fetal echo. So then I went to the imaging search, and I thought, okay, well, can we get some images to show you? The first thing I came to was this guy, who certainly is quite tough, competing in a tough mudder competition and in the mud and grueling events. But then I came across this guy. This is our sonographer, Mike Pearlstein. He's doing a fetal echo, and look at him. Look at those muscles that are tensed and the sweat flying off his brow. He's echoing in a bright room. What else could be more tough? But I scrolled down and got to this picture and thought, this is tough. This is our fellow, Piers Barker, when he was a fellow, holding a live lion. What else could be tougher? Fetal echocardiographers are tough. So what is the reason why fetal diagnoses can be so tough? Well, I think it's because there's so many things that contribute to what makes them tough. We have tough detection, tough anatomy, tough interpretation, tough counseling, tough management decisions, and of course, image quality. And today I'm going to go through a few examples of some of these areas. I'm not going to talk about image quality, but I'm going to start with talking about tough detection, because I think that's where it all begins. Fetal detection of congenital heart disease is tough. Why is this? It's because the majority of fetal heart diagnoses occur in babies of mothers with no risk factors. So the fetuses with heart disease won't get to a pediatric cardiologist and a fetal echo unless they first are detected by our OB colleagues. So we only are ever going to be as good as the OB's fetal heart screen in these mothers. So let's take a look at the fetal heart screen. So we know that for many years, all that was done with these screenings was an apical four-chamber view. And so if the OB got this view of the heart where they saw the four chambers and the heart wasn't enlarged, they said, okay, it's normal. We all know, though, that if we sweep up into the outflow tract views, that many more diagnoses can be detected, particularly with the great arteries. And you can see this patient has a VSD as well as bifurcating pulmonary artery here posteriorly. So this patient has transposition. So when we look at the heart screen in terms of its sensitivity for picking up congenital heart disease, we know that with the four-chamber view alone, the sensitivity is very low, only about 15 to 30%. When we move on to include the outflow tracts, though, we can increase that to up to 80%. And if we use a much more straightforward technique, the three-vessel view, which is a much quicker screening technique, this can be increased to almost 90%. So what is the three-vessel view? So this is a view that the screeners will use when they're looking at the heart to quickly tell if the great arteries are normal. And if you look at this sweep, if you stop it up in the mediastinum, you can get this view where you get the right SVC and the aorta and the pulmonary artery all in a straight line. Now, if you compare this to an abnormal picture, where we get the color flow here to help us out a bit. We have the right SVC in red, and now you can see those great arteries make more of a triangular appearance. This is from the more anterior aorta in this patient with transposition. So this is a quick way to tell if there's an abnormality present. So in 2013, the two major organizations that have guidelines for performance of the fetal screening did recommend including the outflow tract views in their heart screens. So that's very important. Now, if we look at the prenatal detection rate, whoops, I got to go backwards. We certainly know that in the 1990s, this was much lower than it is today, but it has increased through the years. And if we look at the STS database reported by Quartermain, it showed a 42% fetal detection rate of fetal heart disease, and then even in the Netherlands, up to 60%. The issue is here, though, in the Quartermain paper, if you look at the map of the United States, we can see that there's many states where this detection rate is much lower and other states where it's higher. So we still have a lot of work to do. So let's look at transposition as one outflow tract lesion that is notoriously tough to diagnose fetally, but we do know that it's improving. And this study out of Boston shows that if you look back in the 1990s, detection was quite low, and it has increased significantly over the years, but is still less than 50% in 2011. So how can we keep improving this? I think it's going to come with comprehensive programs focusing on that fetal heart screen. And if we look at a couple places that have done this, we can see how that can work. So in the Netherlands, there is a national screening program that was instituted that involved education and examination, both practical and theoretical, for all sonographers. Each were required to do 150 scans per year and had a quality assessment every 2 years. So their detection rate for specifically detransposition increased from 14 to 44% when this program was instituted. And if we look at our own country, the program in Nevada created a community-wide program, and again, statewide, had recurring educational programs for general OB sonographers that also involves scheduling fetal cardiologists out in the practices. And their detection rate for detransposition increased from 25% to 63%. So this is tremendous. So if I look at our own institution, my colleagues who do fetal echoes will feel the information that I have, that we've seen tons more transpositions in our fetal clinics, or at least it feels that way. And if you look at the numbers, we've had about 20 a year for the past years, and the detection rate was somewhere about 50 to 60%. But in the last 5 months, we had 92% detection and double the number of transpositions coming in fetally. Only one patient was diagnosed postnatally. So how can we begin to solve the low detection of congenital heart disease? Well, I think we've come a long way, but I think we have to keep working to have a universal implementation of a quality fetal heart screen. So we need to standardize our technique, allowing for the outflow tracks, and I think also involvement of some color Doppler and cine clips with the screens. And we need to have develop reliable quick screening methods, such as the 3-vessel view and a newer method called the posterior LA space index for diagnosing total veins. And then we need to provide the training and ongoing education of the OB sonographers, and I think that needs to happen through the fetal cardiologists. So let's move on to tough anatomy. And of course, as fetal cardiologists, we love anatomy. But when I went to the sonographers and fellows and said, what do you think the toughest fetal diagnoses are? Of course, they jumped to pulmonary veins, systemic veins, heterotaxy. This is really one thing that really trips a lot of us up, and it really involves the complex cardiac connections. So one thing that I've come up with to help us diagnose these complex cardiac connections are the 4 S's. And this is a sweep of a patient who has complex connections, and you can see a lot of information being thrown at us, but I think we need to move into it one step at a time. So we need to start with the basics. We always need to orient. First thing we do, determine the right and left side of the baby, and we need to determine the heart position and the stomach position after we do that. And you can see in this patient, with the posterior and then the left, you can see the stomach is on the left and the apex of the heart is pointing towards the right. So then we need to stick with the next S, stick with the standard planes, at first at least. We need to have a true axial and a true sagittal plane. And so this picture that I'm showing, which is very off-axis, is showing us some information. It looks like the great arteries are parallel. We see that there may be a VSD, but what we don't know is any right or left information. So it can be very confusing if you start with this view to really understand what's going on. Finally, the next S is the segmental approach, where we really need to take this sweep and take this anatomy one step at a time. And just like we do with our postnatal echoes, we need to go through each step of the connections. So if we do that with this patient, the first image, we can see that we are sweeping up, and the IV and hepatics, which are on the right, are coming into that right-sided atrium. And if we move to the slightly more superior, we see the pulmonary veins are coming into the left atrium. And then moving up to the first AV valve we come to, we can see that there's the mitral valve into what is the left ventricle, which is pointing towards the right. And moving just slightly more superior, we actually get to a very hypoplastic tricuspid valve, which is angled actually towards the left. And then moving from the ventricles to outflow tracts, We see the ventricle here and sweeping up, and we see the two great outflow tracts. One thing we don't see very well from this view is the ventricular septum. Is there one ventricle? Is there two? That's where we need to go to other views, and we can see that there's an outflow tract coming off this ventricle, which is, I gotta move this mouse, I'm sorry, I can't get in there, which is showing that there's a VSD and the outflow tract here, and a separate ventricle which is superior to the larger left ventricle here. So a superior-inferior arrangement of those ventricles. And finally, moving to the outflow tract sweeping up, we see that there's an anterior outflow tract and a posterior vessel that is bifurcating into the PA, so these great arteries are malposed with the aorta directly anterior and sweeping towards the left to the left aorta. So sweeps are our friend. We need to do the sweeps, but we need to take them one step at a time. And we can get all this information from one sweep, but we have to kind of take it each step to get all the diagnoses that we need. So my 4 S's, which are start with the basics, stick with the standard planes, the segmental approach, and the sweeps. And if you have Thor Thorson at your institution, you can have him draw a beautiful picture. This actually isn't the same patient, but does show a beautiful rendition of the two great arteries. So finally, I'm going to tackle tough interpretation, counseling, and measurement decisions. So I just want to point out this is actually our Michigan crew who did the Tough Mudder, and 2 of our wonderful fellows who are imaging fellows, Haley Hancock and Nicole Chrysalia, and they are definitely tough. So this is the diagnosis that I absolutely go crazy with. So fetal diagnosis of RV-LV size discrepancy is very tough. And the problem is that the diagnosis can be such a broad range of things. Is it a coarctation? Is it a borderline LV? Is the LV going to be adequate? Or is it normal? So the issue is that there is such a differential diagnosis when we see this finding. And again, from the wide spectrum of heart defects, but also from some non-cardiac defects. And again, just a normal heart. So when I looked up into the literature, I found many papers that looked at different measurements on the fetal echo and indices and scoring systems that could be used to try to determine which kids were going to have a coarct, which ones were going to have significant ductal dependency, and which ones were going to be more normal. Now, I certainly don't have time to go through all these, but I think it's important that we do try to get together and make a more uniform scoring system. The algorithm published by CHOP was one that I really use pretty often because it's very simple. And just with a few measurements that are easy to obtain in most patients, we can come up with an algorithm to pick out the patients that are going to be higher risk, that need to deliver at a tertiary care center and need prostaglandins, or others that might be able to deliver at a community hospital. So then Trey Jansen, who's one of our former fellows who's here, and I decided to tackle the babies that we were concerned in utero that weren't going to have an adequate left side or the borderline left ventricle. And what we looked at was some indices where in the patients with borderline LV, and we were able to look at their sensitivity and specificity for picking up whether a single ventricle palliation was going to be needed after the babies were born. And if we look at some of these indices, there were a couple that were extremely helpful. So these 2 here, the mitral annulus Z-score and the tricuspid mitral valve ratio, had very high sensitivity and therefore very high negative predictive value. So if we had babies that had measurements that fell outside that cutoff, they were highly likely to be able to have a 2 ventricular repair after they were born. So this was able to pick out some of those patients that we can make a more clear counseling about the outcomes. Then on the other side of the coin, looking for which babies were for sure more likely to have a single ventricle palliation, we found that the LV-RV ratio of the end diastolic dimension was the most helpful. So this had a high specificity, so a high positive predictive value. So if a baby had that ratio greater than 2.1, there was a high likelihood that that baby was going to need a single ventricle palliation. So if we apply this to a couple patients more recently, we can see this patient who has LV-RV size discrepancy. We were able to get these 4 measurements, which are very easy to obtain in most babies. And we can see that this baby had one of those indices that gave it a high negative predictive value for a single ventricle palliation, so therefore high likelihood to be successful 2V repair, which was the outcome. This other patient here, which has also LV-RV size discrepancy, had a ratio of the RV-LV dimensions that showed that there is a high positive predictive value for single ventricle palliation. So this baby did indeed need a single ventricle after they were born. So I know this isn't perfect, but this did help. There were still a lot of patients that fall in the borderline area, but I think it's important that we continue to look at these measurements and hopefully work with each other to find the best measurements. So how do we solve RV-LV size discrepancy in the fetus? We need to have more quantitative measurements. We need to validate these measurements and do multi-center studies, develop algorithms, and then, of course, always individualize our counseling and delivery planning. So I hope I've given you, in this fast, rapid tour through some of the fetal difficult diagnoses, how we can begin to solve some of these issues. So fetal detection, I think we need to have universal implementation and education and ongoing quality control of fetal heart screen. Of complex cardiac connections, we can have our 4 S's. And then the RV-LV size discrepancy issue, I think we need to continue to have more quantification and measurements and standardized algorithms. So with that, I'd like to thank you all for your attention.